Hello, everyone. Welcome to our webinar where we will be reviewing updates in pediatric ambulatory anesthesia led by Dr. Michelle Harvey. I am Sam Saeed, an associate professor of clinical anesthesiology at Children's Hospital Los Angeles, Keck School of Medicine at USC, and chair the ambulatory pediatric anesthesia committee with the SAMBA. I also chair the pediatric liver and intestinal transplant group with the Society of Pediatric Anesthesia, SPA. And I am expert panelist on the committee for airway algorithm with the American Society of Anesthesiologists. For those of you who are not a SAMBA members, please consider joining the society as it offers many benefits to the members. And please visit our website. It's www.sambahq.org to see the benefits of membership. A few quick housekeeping notes before we get today started with our presentation. Please note that this webinar is listen-only mode. In the upper right side of your computer screen, you will see a GoToWebinar control panel. Through this control panel, attendees will have the ability to contact our staff via chat and question boxes. We will have time for QA at the end of the presentation, but please submit your questions throughout so that we can prepare to the answer. At this time, I would like to introduce tonight's speaker. As you already know, our speaker is Dr. Michelle Harvey. Dr. Harvey is a pediatric anesthesiologist at the University of California, Los Angeles. She attended Pomona College in Claremont, California, then went to medical school at University of Chicago Pritzker School of Medicine. She did her residency in anesthesiology at UCLA and fellowship in pediatric anesthesiology at Children's Hospital Los Angeles, then returned to UCLA as faculty. She is Associate Program Director for the Pediatric Anesthesiology Fellowship. She is also the Assistant Medical Director of the Westwood Ambulatory Surgery Center, where she has cultivated an interest in pediatric ambulatory anesthesia. I hand it over to Dr. Harvey for her presentation.
Wonderful. Thank you so much, Sam, and thank you all, everyone, for listening in. As Dr. Saeed said, I'll be talking about updates in pediatric ambulatory anesthesia. I have no disclosures. I'll be discussing three major topics from the literature with updates from the last couple years, mostly focusing from late 2018 to 2020. There are many interesting developments, but today I'll focus on updates regarding caudal epidurals, anesthesia for tonsillectomies, and neurodevelopmental effects of anesthetics. So let's get started with updates in the literature regarding caudal epidurals. I'll touch on two subtopics: the safety of caudals in patients undergoing hypospadias repair and adjuvants to prolong the duration of caudal analgesia. So what is known about caudal blocks and hypospadias repair? We know that caudal blocks are safe and effective. Complication rates, as reported by the Pediatric Regional Anesthesia Network, PRAN, are very low for caudals. Hypospadias repair is known to be a painful procedure, with caudal analgesia being superior to penile block or systemic analgesics. Clustered around 2016 to 2017 and some from before that, there were several studies reporting a possible increase in postoperative surgical complications in patients receiving caudal blocks. These complications included fistula formation, wound dehiscence, diverticula, and urinary retention. The proposed but still theoretical mechanism for the increase in surgical complications with caudals is that sympathectomy leads to engorgement, which leads to vasodilation, venous pooling, and tissue edema. But others argue that the engorgement seen with caudal analgesia is a physiologic process that doesn't lead to edema, and that increased risk with caudal is, quote, biologically implausible. So definitely controversy in the literature. After many retrospective studies and a few randomized control trials several years ago, 3 meta-analyses were published in 2019, combining the data from many of these studies to look at overall complication rates across studies. So let's take a look at those meta-analyses. In this meta-analysis from 2018, there were 9 studies, including over 2,000 patients that were analyzed. All were retrospective studies, except for one randomized control trial. They compared postoperative complication rates between patients receiving a caudal and those receiving any other analgesia. There was an increase in post-op surgical complications in the caudal group with an odds ratio of 2.32. When the proximal hypospadias alone was looked at, cases alone were looked at, the odds ratio was higher, 3.55. For distal hypospadias, the odds ratio was 1.31 with a lower limit of the 95% confidence interval below 1. So since this data is mostly retrospective, it is possible that there was some selection bias toward doing a caudal for proximal hypospadias cases, which are more complicated, bigger cases, and proximal repairs were the source of the increase in complications. In another meta-analysis, also from 2019, observational studies were analyzed separately from the randomized control trials. So in the observational studies, caudal blocks were not associated with complications with an odds ratio of about 1.8. And when only distal hypospadias was analyzed, the odds ratio was 1.02. So then for the randomized control trials, one study showed a huge difference in complication rate with no difference found in the other 3 randomized control trials. For the study that did find a large difference, only distal hypospadias cases were included. All of the complications were reported in the caudal groups and none at all in the control group. And all complications were urethral fistula occurring within 2 to 4 weeks. Their incidence of urethral fistula formation after distal hypospadias repair was 19%, kind of alarmingly high and maybe not reflective of usual complication rates. So for that study, there is some question about confounding by surgical technique, different surgeons, and this kind of result has not been replicated. In this last cluster of meta-analyses, they found a 12% versus 5.8% risk of fistula formation in the caudal versus no caudal groups with an odds ratio of 2. No subgroup analysis was done in this study. So how does this affect our management of patients undergoing hypospadias repair? The literature is somewhat difficult to interpret, given that there are a few studies that show huge differences, with most studies not showing much or any difference in the complication rates. I would have hoped that these meta-analyses might help clear things up, but all 3 took very different approaches and came up with slightly different results. Personally, I have not changed my practice of doing caudal blocks for these patients, though most of the patients I see happen to be having distal hypospadias repair, and the surgeons I work with generally have low complication rates. I would be more cautious in patients having proximal hypospadias repair and have a discussion with the surgeon, though I wouldn't rule out the possibility of safely doing caudal analgesia in these patients. I'll next discuss emerging literature on adjuvants to caudals. A typical caudal block with bupivacaine or ropivacaine lasts about 4 to 8 hours. In most studies in children, this is measured by the time to first analgesic dose. All of the adjuvants listed given by the caudal route have been shown to prolong the duration of analgesia significantly. In regards to ambulatory surgery, opioids do cause some respiratory depression, so patients should be monitored for up to 24 hours after neuraxial administration, making this not very practical. Ketamine has no significant side effects when given by the epidural route in children, but a preservative-free version is not readily available, and there are concerns about neurotoxicity when given via this route. Clonidine has been shown to prolong the duration of the caudal, but also to increase sedation in some studies, but not others, and also should probably be avoided in children under 1 or about 10 kilos, given reports of bradycardia and respiratory depression. So I will discuss a couple of new studies or reviews regarding dexmedetomidine and dexamethasone. So first, 2 studies addressing dexmedetomidine. This meta-analysis from 2020 looked at data from 12 randomized controlled trials to evaluate the efficacy and safety of caudal dexmedetomidine. They were able to show that there was a significant increase in the time to first rescue medication with a weighted mean difference of about 7 hours. The dose of dexmedetomidine used in the studies varied from 1 to 2 micrograms per kilo, and they showed a decrease in sevoflurane requirement, an increase in the time to eye opening from the end of anesthesia by about 17 minutes, and an increase in sedation scores at 2 hours. It's unclear how clinically significant that increase in sedation scores was and how it might affect discharge from the ambulatory setting. But from this study, we can see that a significant effect on time to first pain medication, decreased need for systemic anesthesia, and a longer time to wake up and more sedation in PACU. This next prospective randomized double-blind placebo-controlled trial compared 3 groups. All received a caudal with levobupivacaine, 0.25%, 1 ml per kilo. One group also received 1 microgram per kilo of IV dexmedetomidine, and one group also received 1 mic per kilo of caudal dexmedetomidine. On the top right, you can see that the time to first rescue analgesia was significantly longer in the 2 groups that received some form of dexmedetomidine. In the table below, there was indeed a significant increase in time to first analgesia, 12 and 14 hours in the dexmedetomidine groups and 6 in the control group. The delirium scores were less in the dexmedetomidine group as expected, as was the incidence of emergence agitation. Emergence time was significantly longer in the dexmedetomidine groups with a mean difference of about 6 to 8 minutes. However, duration of PACU stay was not increased. So conclusions from this study are that the benefits of IV and caudal dexmedetomidine do seem similar. So given the off-label use of neuraxial dexmedetomidine and limited safety data, IV administration may be preferred. And in the ambulatory setting, one should be aware of the possible increase in time to emergence. So moving on to dexamethasone as an adjuvant, there have been many good randomized controlled trials demonstrating that caudal and IV dexamethasone can prolong the duration of caudals. More of these studies have looked at caudal than IV use. The goal of this systematic review and meta-analysis was to look at the efficacy as well as possible steroid-related morbidity. And they found that dexamethasone significantly prolonged the duration of analgesia by about 5 to 6 hours when used by either the caudal or IV route. And other benefits included reduced opioid use, less post-op rescue analgesia, and lower PONV via both routes. Theoretical concerns regarding steroid administration include delayed wound healing, surgical site infection, and hyperglycemia, but no difference was found in any of these parameters. This meta-analysis, published about the same time, looked only at 7 randomized controlled trials. They grouped patients that received dexamethasone via any route together and compared them to a control group which only received local anesthetic in the caudal. They found that the duration of analgesia was prolonged by about 4 hours in patients receiving dexamethasone, somewhat similar to the results from the last study. However, there was no subgroup analysis for comparing IV to caudal administration. So given that there is some concern about neurotoxic effects of epidural dexamethasone on the immature nervous system and epidural use being off-label, the results from Chong and colleagues, the study on the last slide, that IV works just as well as caudal dexamethasone is helpful. And it is worth noting that the IV dosing used in the studies reviewed was 0.5 milligrams per kilo, quite a large dose. It would also be interesting to know if lower doses worked just as well. That concludes the section on caudals. We'll spend the next third of the talk discussing tonsillectomy. I think it's important to discuss these cases in a pediatric ambulatory talk because they're the second most common ambulatory surgical procedure in children. First, of course, is ear tubes. In 2010, 289,000 ambulatory tonsillectomies were done in children under 15 in the US, and about 2/3 of those were for obstructive sleep disordered breathing. The remaining third were for recurrent throat infections. I'll frame this discussion by addressing guidelines relevant to anesthesiologists for tonsillectomy from the American Academy of Otolaryngology Head and Neck Surgery's latest guidelines, focusing on obstructive sleep apnea and opioid-sparing analgesia, as well as some other topics sprinkled in there. So in 2019, the American Academy of Otolaryngology Head and Neck Surgery published an updated guideline for tonsillectomy in children. The previous set of guidelines was from 2011. There are several statements relevant to anesthesiologists, and I'll discuss those. So one of the recommendations is a strong recommendation against perioperative antibiotic administration. This is not a new recommendation, only the wording was changed from should not routinely administer antibiotics to just plain should not administer antibiotics. Exceptions, though, would include patients with active peritonsillar abscess or those that require endocarditis prophylaxis. On this slide are recommendations regarding sleep disordered breathing and obstructive sleep apnea. So first, polysomnography is recommended for children with sleep disordered breathing if they are less than 2 or have any of the following: Down syndrome, craniofacial abnormalities, neuromuscular disorders, sickle cell disease, or mucopolysaccharidoses. Second, if the need for tonsillectomy is uncertain or there's some confusion, then polysomnography is indicated. And third, tonsillectomy is recommended for children with OSA, documented by a polysomnogram. And last, inpatient monitoring is recommended for children under 3 years of age, those who have severe OSA, defined here as an AHI greater than or equal to 10 or an oxygen saturation nadir of less than 80%. So this means then that the vast majority of patients undergoing tonsillectomy for presumed sleep disordered breathing will not have sleep studies prior to undergoing surgery. And how can we risk stratify them? So let's talk a little bit about OSA and sleep disordered breathing. What exactly is sleep disordered breathing? It's a spectrum of disorders, including snoring, central sleep apnea, OSA, and sleep-related hypoventilation. As I mentioned before, it's the most common indication for tonsillectomy and adenoidectomy. Only an estimated 10% of patients with sleep disordered breathing have a sleep study prior to surgery. And this makes sense because sleep studies are expensive, time-consuming, somewhat disruptive. Many kids with a presumptive diagnosis of OSA or sleep disordered breathing will get better with tonsillectomy, so it may be unnecessary to do this additional testing. But what if we did have more information about the severity of OSA and what kind of disordered breathing was occurring? It might change our management of the anesthetic. It might change whether premedication is given, how a patient is induced, how their airway is managed, the choice and dosing of analgesics, the risk of perioperative pulmonary complications, for how long they're monitored on PACU, and their disposition, whether to home or admitted to the hospital or in a PICU bed. There are no specific recommendations for monitoring of pediatric outpatients with obstructive sleep apnea, but the ASA does recommend monitoring until patients can maintain oxygen saturation on room air at rest and preferably while sleeping. To demonstrate this point about how more information could be helpful, a recent study was published in which pediatric anesthesiologists were asked to fill out an online survey. Of 110 respondents, 46% worked in a freestanding children's hospital, 33% in a mixed hospital, and 75% top residents. The comfort of the respondents with managing pediatric patients with OSA was about 85% on a scale of 100. So remember, this is all survey data. When asked what pre-med they would give to patients with OSA, 53% would give oral midazolam, 11% would give no pre-med, and 25% would do a parent-present induction. 25% would change their pre-med plan based on a diagnosis of OSA, and almost all would do an inhalational induction on a hypothetical 6-year-old patient with severe OSA. So it may not change one's actual induction strategy. For pain management, 68% would give fentanyl. The usual dosing was 1 to 2 micrograms per kilo. 20% used morphine, and 15% would give no narcotics. 98% would give dexamethasone, 63% would give IV acetaminophen. There was no comment on oral or rectal acetaminophen, and 8.2% would give IV NSAIDs. An additional 8.2% give IV NSAIDs sometimes, and 83% don't use IV NSAIDs. So it makes sense that anesthesiologists would try to minimize opioid use and maximize non-opioid analgesics, given that patients with OSA have an increased sensitivity to opioids. They are known to be more prone to respiratory depression and also require a lower dose for therapeutic effect. 73% of survey respondents said they would extubate the patients awake, while 13% would extubate deep. Several studies have demonstrated the safety of deep extubation even in patients with OSA, though it's still not widely used. This survey did not address LMA use. Most anesthesiologists prescribe opioids for PACU, with 12.7% saying they don't prescribe any. For patients who are also obese, 42% would change their protocol if a theoretical patient was 6.5 and had severe OSA and obesity. Most would use ideal body weight for pre-med dosing and opioid dosing, And this is consistent with recommendations to dose opioids based on ideal body weight, since opioids don't distribute as much into the fat, leading to relatively higher plasma concentrations. So knowing that our anesthetic plans will likely change, or at least be tinkered with, depending on the presence and severity of OSA, it might be nice to have more information for more of our patients. So one hot topic is the use of nocturnal pulse oximetry. Polysomnography is the gold standard for diagnosis of OSA. However, it can be expensive, time-consuming, resources are limited, and it does require an overnight stay. In adults, home sleep apnea testing, or this nocturnal pulse oximetry, has been shown to be non-inferior to polysomnography in evaluating OSA and is well accepted as a part of sleep evaluation. There's debate in the literature about the utility of home pulse oximetry for screening pediatric patients for OSA because there are many, it can't assess some variables like arousals from sleep, it can't differentiate obstructive versus central apneas, and it can't estimate total sleep time. So back in 2000, Briette et al. Did a nice study that showed nocturnal oximetry to be a good diagnostic tool given a high positive predictive value. However, it had low sensitivity, so polysomnography was still recommended if nocturnal oximetry was negative or inconclusive. The aim of this study on the top here by Jonas and colleagues in 2019 was to determine the sensitivity of nocturnal pulse oximetry for the diagnosis of OSA compared with polysomnography. So when polysomnography is performed, the diagnosis of OSA is based on the apnea-hypopnea index as defined by the American Academy of Sleep Medicine. Often the oxygen saturation nadir is also considered, but for this study they used just the AHI. So mild OSA is an AHI 1 to 5, moderate 5 to 10, and severe greater than 10. When using nocturnal oximetry, the McGill oximetry score is used to evaluate the severity of OSA. You can see here if there are less than 3 drops in the oxygen saturation below 90%, the study is negative or technically inconclusive, given past data recognizing that there is low sensitivity. Mild OSA is defined as at least 3 drops below 90%, but less than 3 drops below 85%. Moderate OSA is at least 3 drops below 85%, but less than 3 drops below 80%. And severe OSA has at least 3 drops below 80%. And any patient with clusters of desaturations defined as 5 DSATs more than 3% from baseline automatically has at least mild OSA. So this study was done in patients 1 month to 15 years, most being under 5 years old. 110 children were included who happened to have had both studies within a 3 to 4 month period, and those reading the sleep studies were blinded to oximetry results. In patients with moderate or severe OSA by oximetry, 100% had some degree of OSA on polysomnography, and most were confirmed to have moderate or severe OSA. In patients who tested as having mild or no OSA on oximetry, the results were less consistent. For those with a McGill score of 1, which would be a negative or inconclusive result, OSA was actually diagnosed on polysomnography in a third. For a McGill score of 2, which would be indicative of mild OSA, moderate or severe OSA was actually confirmed in 30% of the patients. So these results are pretty consistent with the study from 2000. That nocturnal oximetry could be used as a screening test, especially when polysomnography is not available, but it does not exclude OSA if they have a McGill score of 1, and it does not exclude moderate to severe OSA if the McGill score is 2. But if perioperatively in our population we are concerned about moderate to severe OSA and we will change management or overnight monitoring depending on that diagnosis, it could be better than no test, and that it would pick up many of the patients with moderate to severe OSA. But again, a negative test would not exclude moderate to severe OSA. So now to address some studies regarding pain management for patients undergoing tonsillectomy. The 2019 guidelines more strongly encourage clinicians to counsel patients and caregivers regarding the importance of and how to manage post-tonsillectomy pain, and recommends that they should reinforce this counseling at the time of surgery. This is usually done by the surgeon, but collaboration and consistency between the surgeon and anesthesiologist is important. This study was a multidisciplinary QI project at a tertiary academic children's hospital. Prior to implementing 2 changes, patients received 30 dose equivalents of oxycodone 0.1 milligrams per kilo to take home, and the recommendation to caregivers was to give acetaminophen and oxycodone around the clock for 48 hours with ibuprofen PRN. For the intervention, the group implemented a plan to decrease prescriptions from 30 to 20 dose equivalents of oxycodone and educate caregivers to give acetaminophen and ibuprofen around the clock with oxycodone only as needed. All perioperative education was at the discretion of the surgical and anesthesia teams, but this was the department's agreed upon recommendation. The study included 693 patients, ages 1 to 11, having tonsillectomy. So on the dark blue line, you can see a significant drop in opioid prescription quantity from about 30 to 20 as per recommendations. On the light blue line, there was an increase in education to use non-opioids from about 70 or 80% to 80 to 100%. And on the gray line, there's an increase in caregiver reported, quote, good pain control rather than adequate or poor pain control. You can see a little more detail here with less opioid prescription quantity, more education, and more good pain control. However, 14% still had poor pain control compared to 11% pre-guideline. You can see a trend toward more non-opioid use, but not necessarily less opioid use. And interestingly, in both groups, a very low percentage of patients required refills. There's no increase in post-tonsillectomy hemorrhage detected in the post-guideline group. So this study showed that caregiver education may provide an opportunity to improve pain control and reduce opioid prescribing, but it was underpowered to detect a true difference in pain control. 2 more pain-related guidelines are shown here. There's a strong recommendation against perioperative coding, and this should not be a surprise. Just as a reminder, polymorphisms in the CYP2D6 gene lead to variation in efficacy and safety. 8 to 10% of children are slow or non-metabolizers, so it's not effective, and 0.5 to 2% are rapid metabolizers, converting codeine to morphine very quickly and producing a higher blood level than expected. Same can happen with tramadol. There's also a strong recommendation for using ibuprofen, acetaminophen, or both for postoperative pain control. There are no specific recommendations for intraoperative use of ibuprofen or NSAIDs or acetaminophen. So there have been mounds of studies comparing different analgesic techniques for tonsillectomy over the years. If there were a silver bullet, I would present it. The general trend, however, is toward opioid sparing, and I'll present a couple recent studies showing how some institutions have approached this challenge. The benefits of opioid sparing would be that it would reduce respiratory depression and possibly postoperative respiratory complications, reduce PONV, and spare a valuable resource during drug shortages. Options that have been used for multimodal analgesia include acetaminophen, NSAIDs, dexamethasone, dexmedetomidine, ketamine, opioids, and non-pharmacologic interventions such as distraction, ice popsicles, ice packs to the neck and ears, screen time. I will discuss a few of these multimodal options. So first we'll talk about ibuprofen. It's a reversible inhibitor of platelet aggregation, and that's where some of the concern comes from. Several meta-analyses have not shown increased post-tonsillectomy bleed with NSAIDs in children. Just as an example, there was a large meta-analysis from 2013 of 35 randomized controlled trials, which showed no significant difference in bleeding between patients receiving NSAIDs and those not. There was one subgroup analysis of patients receiving NSAIDs post-op only, which did show a slightly increased bleeding risk, but most retrospective studies of post-op ibuprofen have found no difference, and individual randomized controlled trials of ibuprofen have been powered only to detect analgesic effect, and they haven't been powered to look at postoperative bleeding. So I'll present one randomized controlled trial that does directly address the issue of post-tonsillectomy bleeding with ibuprofen from June of 2019. This was a randomized controlled trial at 4 tertiary medical centers with 741 cases total. Patients were randomized to receive 10 milligrams per kilo of ibuprofen or 15 milligrams per kilo of acetaminophen Q6 hours for the first 9 postoperative days with an intention to treat analysis. The main outcome measure was type 3 bleed. A type 1 bleed is bleeding at home or evaluated in the ED with no intervention. Type 2 bleeding requires readmission, and type 3 bleeding, the primary outcome of the study, was bleeding that required a return to the operating room for control of hemorrhage. They set the non-inferiority margin at 3%. There was a trend toward more of each type of bleeding in the ibuprofen group. For the main outcome measure, there was a 1.17% difference from 1.2% risk of bleeding in the acetaminophen group to 2.3% in the ibuprofen group. However, looking at the bottom right, the confidence interval exceeded the 3% non-inferiority cutoff, so they could not demonstrate non-inferiority of ibuprofen for type 3 bleeds. One caveat is that when only including patients whose questionnaires were returned completely, making it a per protocol analysis, they were able to demonstrate non-inferiority of ibuprofen. This might be more accurate because all patients lost to follow-up were presumed to have not bled, but it's also making it a small sample size, so the results are a little more difficult to interpret. As far as any verdict for ibuprofen, much less ketorolac, most studies do show analgesic benefit. Results are mixed when trying to prove that there is absolutely no difference in bleeding with NSAIDs, but many do provide comfort in that either no difference or a very small difference in bleeding is found. The benefit of ibuprofen or NSAIDs to some patients, especially those with OSA, where you could reduce opioid requirements, but at the expense of possibly a slight bleeding risk, might be worth it, but in some populations that increased risk might not be worth it. Dexmedetomidine has also been used as part of a multimodal approach to pain management, to post-op management of tonsillectomy patients. There are many studies looking at dexmedatomidine's effect on post-op pain and emergence delirium, with most studies showing a benefit. The downside of dexmedetomidine for outpatient surgery is cost and delayed emergence or discharge. This study is a randomized controlled double-blind study of dexmedetomidine half a microgram per kilo versus saline as a control in 90 patients ages 2 to 7 undergoing tonsillectomy plus or minus adenoidectomy. And the primary outcome they were looking at was emergence delirium at 30 minutes. So you can see on the top graph, there's a significant decrease in the incidence of emergence delirium based on the Pediatric Anesthesia Emergence Delirium Score. The primary outcome of the study, so they showed that difference. The graph on the bottom shows the incidence of negative postoperative behavioral changes, such as excessive dependence on parents, sleeping and eating disorders, nightmares, and temper tantrums. In the dexmedetomidine group, there are significant differences at 1 and 7 days, with no difference seen at 30 days, and the incidences in control groups are similar to other studies. Additionally, they found significant decreases in maximal delirium scores, maximal FLAC scores, and a trend toward decreased incidence of sentinel rescue. The time to extubation, which was defined as time the SIVO was turned off to tube out, was significantly longer, but PACU length of stay was not longer once extubated. So I think dexmedetomidine clearly has benefits. The question is, are these worth the cost of the drug and the longer emergence? Usage may depend on the ability to split vials and PACU resources. This is another study utilizing dexmedetomidine as part of an opioid-sparing quality improvement study. This was undertaken during the opioid shortage as a way to conserve resources. So this surgery center utilizes standardized clinical protocols for multiple procedures, including tonsillectomy. The usual practice was to, prior to the QI project, was to give morphine 0.1 milligrams per kilo and acetaminophen IV 15 milligrams per kilo for tonsillectomies. The study used PDSA cycles, so the first cycle changed the the analgesic regimen to ibuprofen 10 milligrams per kilo PO and dexmedetomidine IV 1 mic per kilo. And the ibuprofen was given 5 minutes before induction. For the second cycle, they changed to ketorolac IV 0.5 milligrams per kilo and continued with the dexmedetomidine. Primary outcomes were maximum pain score and post-op morphine rescue rate. Other outcomes measured included PO&B, PACU length of stay, total anesthesia time, and reoperation. These here are X-bar charts. The top one is for mean pain scores, and along the x-axis is time. So their baseline is in blue. The first intervention with ibuprofen and dex in orange seems to stay above the mean for the morphine acetaminophen group. And there were 13 points in a row above the mean, indicating that there was a significant change, meaning more pain actually with this regimen. On the bottom chart for the orange section, there was a trend toward more frequent morphine requirements, but no significant change, no special cause variation. Looking at the green lines, that's where they made the second change to dexmedetomidine and ketorolac. And you can see that it looks very similar to the pain scores from their baseline for the morphine acetaminophen group, showing non-inferiority for pain management with dexmedetomidine and ketorolac. And this graph shows the PACU length of stay. In the orange section, that was clearly increased in the dexmedetomidine ibuprofen group, but this improved in the green section with dexmedetomidine and ketorolac. And the explanation for this could be increased or better pain management in that group, or that the providers became more adept at using dexmedetomidine and assessing patients who have had it and therefore discharging them earlier. So conclusions from this QI PDSA study are that dexmedetomidine and ketorolac did not seem inferior to morphine and acetaminophen as far as pain scores, recovery times, PACU length of stay, or duration of anesthesia, and they were able to reduce morphine use to 20% of their patients from 100%. This is the last of the tonsillectomy guidelines I'll cover. There's a strong recommendation for single intraoperative dose of IV dexamethasone in children undergoing tonsillectomy. Benefits of steroids have been shown to include decreased incidence of PO&B, decreased time to first oral intake, and decreased pain. I'll present one recent study that demonstrates the benefits of steroids for tonsillectomy patients. This was a systematic review of IV, local, and oral steroids in decreasing post-tonsillectomy pain and nausea vomiting. There were 64 studies with over 6,000 patients included. And just want you to look at the kind of big picture here. This forest plot shows the effect on PO&B of different routes of dexamethasone administration. It shows a general trend toward the left of center, that neutral line in the middle, meaning that there was less PO&B with patients who received steroids. The total at the bottom was an overall odds ratio of 0.31, and there's a significant reduction in PO&B with IV steroids and local steroids, but no significant reduction with oral steroids. This forest plot shows the effect on pain in the first 24 hours. Both IV or local steroids significantly decreased pain on postoperative days 0 and 1. And I won't show all the graphs, but there was a significant decrease in pain with when steroids were given for all 4 time periods they looked at: first day, post-op day 1, 3, and 7. A subgroup analysis of pediatric patients was analyzed because the whole study included adults too. Most of the studies used dexamethasone 0.5 milligram per kilo for the children. The results for IV steroids were consistent with the overall group, and for local steroids there was significant pain reduction up to 3 days post-op and no other major differences in outcomes. So a summary of tonsillectomy updates. The careful selection of patients for outpatient surgery is warranted. Evaluation for OSA is important as it may change management, and nocturnal oximetry could be useful as a confirmatory test, but used as a screening test, it cannot rule out OSA. Dexmedetomidine decreases emergence delirium, post-op behavioral changes, but maybe increases the time to emergence. It's possible to decrease intra-op and post-op opioid use in this population with a multidisciplinary approach. NSAIDs are helpful for post-op pain, and may have at most a small increase in post-op bleeding. Dexamethasone is very useful for decreasing pain and PONV. And of course, no codeine and no perioperative antibiotics. So the last bit of this talk, we'll talk about neurocognitive effects of anesthetics. This is a topic that's important to understand as anesthesiologists, as it affects our choices and dosing of anesthetics, as well as how we discuss risks and benefits of procedures in anesthesia with patients and colleagues. I will review emerging literature from the past couple of years. For a little bit of background, this is the Smart Tots consensus statement. It is worth a read, and their website has great resources for clinicians as well as parents, and it's a great place to refer parents. In 2016, another piece of history here, the FDA released a statement that, in quotes, is warning that repeated or lengthy use of general anesthetics and sedation drugs during surgeries or procedures in children under 3 may affect the development of children's brains. A little later on in the statement, they say to better inform the public about this potential risk, we are requiring warnings to be added to the labels of general anesthetic and sedation drugs. The list of those drugs is on the screen. Why those were chosen and not others is not clear, but this is the list of medications. So to give an update, I'll start with the state of the literature at the end of 2018. This slide is adapted from Andrew Davidson's talk at the Society of Pediatric Anesthesia earlier this year with permission. He is an expert in the field of neurotoxicity and the first author of the first gas study, and he summarizes it as follows. There's strong evidence for an association between major surgery in neonates and increased risk of poor neurodevelopmental outcomes. Good evidence for an association between exposure in early childhood and a very small difference in school grades. Mixed evidence for an association between exposure and learning disability and diagnosed disorders. Mixed but generally poor evidence for an association with a few different subdomains of neurodevelopment. Some evidence that there's no association with reduced IQ, mixed evidence that the effects are greater with multiple exposures, and little, if any, evidence that the effects are greater in infants. This slide is that the gas study is a well-known study in which patients under 60 weeks post menstrual age were randomly assigned to receive awake spinal or general anesthesia for hernia repair. The primary outcome was neurodevelopmental outcomes at 5 years old, but a secondary endpoint, neurodevelopmental outcome at 2 years old, was published in 2016. No difference was found between the two groups, with the conclusion that less than 1 hour exposure to sevoflurane did not increase the risk of adverse outcome. And in 2019, their results of their primary endpoint were published, the 5-year results. No difference was found in the primary outcome measure, IQ, and many secondary outcomes were studied, including domains such as verbal, language, attention, and executive function, memory and learning, and sensory motor. No differences were found between groups, except in one scale of a parent rating of executive function. Interestingly, 5 other measures of attention and executive function given in this battery of tests showed no difference between groups. Good to note. The MASS study is another well-known study. To review, their initial results were published in 2018. They enrolled children from Olmsted County, Minnesota, who had either no exposure to anesthetics, a single exposure, or multiple exposure before age 3. They were propensity matched and asked to undergo comprehensive neuropsychological testing. For the primary outcome, IQ, no difference was found. And for secondary outcomes, children who had multiple exposures had decreased processing speed and fine motor abilities, but no difference in attention, problem solving, or memory. The parents of multiply exposed children reported increased problems related to executive function, behavior, and reading. Interesting because this also popped up in the GAS study. Possible confounders, though, of this study are selection bias, in that parents who enrolled may have had more concerns, and they do not account for an indication for or type of procedures being done. The confounding effect of underlying illness and the effects of stress and surgery is still possible despite matching. Results from one of the secondary outcomes of the MASS study, the operant test battery, were published in 2019. The operant test battery performance on that is impaired in infant primates exposed to ketamine. So the study aimed to see if a similar pattern would be seen in humans. It's a 1-hour test of multiple domains that has been shown to correlate with IQ, and none of the OTB test scores depended on anesthesia exposure. This study for 2019 looked at the difference between anesthesia exposure and neurocognitive outcomes in survivors of childhood ALL. 302 eligible survivors were asked to participate, 212 completed participation, and the authors compared cumulative doses of all anesthetics and sedatives with neurocognitive testing. This table shows the relative risks of global neurocognitive impairment, defined as 3 or more tests falling at least 2 standard deviations between the adjusted mean. The data is controlled for age at diagnosis and chemotherapy exposure. They found a significant increase in impairment with a higher cumulative dose of propofol, number of exposures to inhaled anesthetics, as well as cumulative anesthesia duration. Limitations of this study are that there is no control group and there's no baseline data, and it is possible that anesthesia exposure is a proxy for severity of illness. This study by O'Leary and colleagues in 2019 looked at sibling match pairs performance on an early developmental instrument taken by children entering primary school in Ontario, Canada. Among discordant sibling pairs, meaning that one child had an exposure to anesthesia and one child did not, there was no difference in mean scores or numbers testing in the bottom 10%. These results are consistent with other twin and sibling studies where differences may have been found in large cohorts, but discordant twin and sibling pairs did not significantly differ from each other. And that may mean that heritable factors and lifestyle differences may affect development more than the effect of anesthetics. One more study from 2020 looked at the association between a single exposure to anesthesia before 5 years old and persistent use of ADHD medication based on Medicaid data. Children with an exposure were 37% more likely to have persistently use ADHD medication. And of note, that difference much of that difference can be attributed to a subgroup who had tonsillectomy and adenoidectomy, and we know that there can be some neurologic effects of OSA. Also, by using Medicaid data, this study may have evaluated children who were particularly vulnerable to neurotoxic exposures, but nevertheless, the results are consistent with some other studies that suggest a possible increase in ADHD among children with an early exposure to anesthesia. So this slide again is adapted from Andrew Davidson's talk. This is a summary of new evidence in humans since 2018. And the kind of state of the literature is that anesthesia has no impact probably on IQ. There's evidence for an association with readiness for school is weaker. There's evidence for an association with specific behavioral elements of the psychometric testing that remains weak. There's evidence for an association with ADHD remains weak. Increasing evidence of a disconnect between animal and human data, and major surgery in neonates is still associated with poor outcome, but this may have nothing to do with neurotoxicity. So where does this leave us? I think being aware of the latest evidence helps us to be able to confidently discuss questions of surgical or procedural timing as consultants, choose appropriate anesthetics, and discuss risks and benefits of anesthesia with concerned parents. And this area of the literature is evolving, and there are good studies in the pipeline. But as of now, we know that neurocognitive outcomes are multifactorial. There's a disconnect between animal and human studies. If there is an effect of anesthesia, it's likely quite small, but we should limit exposure to infants and children whenever possible and delay exposure whenever possible. So I hope you enjoyed this whirlwind through updates in 3 topics relevant to pediatric ambulatory anesthesia. We covered caudals and hypospadias repair, adjuvants to caudals, all sorts of tonsillectomy updates, and covered the latest literature on neurodevelopmental effects of anesthetics. I'd be happy to take any questions, and thank you for your time.
Thank you very much, Dr. Harvey, for a wonderful and very informative presentation on a major 3 topics in the pediatric ambulatory anesthesia. We got actually quite a bit of few questions here. It shows quite a bit of interest in the topic. First came 13 minutes into our presentation is Dr. Leo Rodriguez. He is the president-elect of the SAMBA. Thank you for attending our webinar. And the question is, what is your favorite caudal cocktail dose and volume that gives you good analgesia and less chance of urinary retention?
So I am pretty boring. I use bupivacaine with epi because that's what we have at our surgery center. I do use IV dexamethasone, usually rectal or oral acetaminophen and IV ketorolac at the end. And I choose IV dexamethasone because of the studies that I presented. As far as urinary retention, I haven't noticed any problems with that, but I haven't tinkered with urinary retention specifically in mind.
Yeah, I think generally speaking, urinary retention is not that common of an issue, I think, in pediatric caudal analgesia. Every blue moon we may see an issue with immobility of the legs, but usually with very short surgical procedure. Another question from Dr. Catherine Tobin, which she is the CME committee for the SAMBA, and she has two questions. One is, do you have any certain age that you are admitting patient for at least 23 hours observation after tonsillectomy? And the second, do you use ketorolac in your tonsillectomies personally? Might you consider if child has severe OSA with high apnea-hypopnea index, HI?
So as far as admitting patients or doing a 23-hour stay, we follow the guideline, the ENT guidelines of children under 3 or those with severe OSA if we know about it. We have been sending home some older 2-year-old patients who are having an extracapsular tonsillectomy with thought that there might be less chance of bleeding and swelling and it's less painful, but that's rare. And then as far as ketorolac, I have had zero luck getting surgeons on board with NSAIDs for tonsillectomy, so I haven't used it at all, but I would love to.
This is a question
about ketorolac, but
okay. This is a question came late, but I think it's interesting from Dr. Ryan Sheng. Oh, I'm sorry, maybe before that there was a Dr. Richard Hoberman. I have a surgeon who swears that muscle relaxation for tonsillectomy is the key to postoperative pain reduction, and any evidence? So, interesting question.
Not that I know of, but that would be interesting.
Okay, I'm not aware of any too. But it would be interesting to have any prospective study or even retrospective study comparing those population. That would be a good question for a futuristic study.
And I'll be wondering, emergence, coughing and bucking and all that contributing. So if there's a way to bypass that with muscle relaxation, or that would be great.
Right. There's an earlier question from Dr. Henry Jason Daz. Hi, do you have any comments or inputs comparing original pudendal block versus caudal anesthesia for hypospadias repair?
Yeah, so I actually was going to talk about that, but took it out for time management sake. So an alternative to caudals for hypospadias would be pudendal block. So pudendal nerve supplies the dorsal penile nerve and the perineal nerve, which supplies most of the penis. But for proximal hypospadias repair, some of the proximal innervation comes from the ilioinguinal and iliohypogastric nerve. So those would not be blocked with the pudendal nerve. So you could probably cover distal hypospadias pretty well with it, but not proximal hypospadias. And proximal hypospadias is where kind of the problem might be with caudals. So you would also need a multimodal approach.
I think it's also a related question from Dr. Adavi Naik. What is your practice for distal and proximal hypospadias repair in the ASC? What are you using and what if you are using any of the additional meds that you discussed?
Yeah, so I do cuddles for distal hypospadias since about 2017 or 2018 when this data was coming out, and we've had our first journal club on this. I haven't actually had any proximal hypospadias cases. That would be kind of a test of my trust of where this is all going. But for distal hypospadias, I still do feel comfortable. Our surgeons are very skeptical of the data that there is any problem associated with cuddles, and they don't see that in their practice. And so they are big fans of cuddles. I do use, I don't use quite 0.5 milligram per kilo of dexamethasone, but I use a larger dose of dexamethasone IV, acetaminophen, and ketorolac.
Another question that's actually interesting about from Dr. Manuel Perez, the dose of dexamethasone you mentioned in pediatric tonsillectomy was 0.5 milligram per kilogram, which is a higher dose than what they usually use. I think it's 0.15 milligram per kilogram, which is probably, he's referring to the P1V dosage. Is that the current standard dose we should be using?
I think a higher dose than 0.15 should be used. I think of P1V dosing being somewhere between 0.1 and 0.2 milligrams per kilo, and a dose for airway swelling or this post-tonsillectomy type pain would be closer to 0.5 milligrams per kilo. I will say that I don't always use the full 0.5 milligrams per kilo because sometimes it just feels like a lot, but and definitely not more than 10 milligrams. But yes, I think something closer to the 0.5 is what we should be using.
Yeah, that was my question too. In this study particular, did they have a max dose? Is it 10 milligram up to 20 milligram?
Yeah, it was 0.5 milligram per kilo, max of 10, and that was in pretty much all the studies.
Regardless of the weight, yeah. So we answered this question about the surgeon who believe in muscle relaxation. Try not to skip any. So Dr. Ryan Shang, healthy 14-month-old child, would you schedule an elective circumcision, general plus caudal, or wait when the child is older?
You said 9 months old?
I think 14-month-old. Yeah. I don't see any problem with that, right?
Yeah. We sometimes encourage them to wait till after a year. That's a very arbitrary kind of cutoff. The FDA warning says after 3, but it is a little impractical to wait for that long. But it is.
I think he intentionally mentioned the elective circumcision because its procedure can be postponed. And that's something it's definitely need to be discussed on a bigger spectrum between anesthesiologists and urologists based on the current gas study information and the most updated information Dr. Harvey mentioned in outweighing the risk and benefits, and what would be the thing you would do for your own child. If it's orthopexy, that's a different, of course, approach, because definitely they need to do it usually in the first year of life and about 8 or 9 months of age. I think that reach us. There's more questions, but I think we got all the time in our hands here, and we appreciate all the audiences. So you can also thank you for all participants in this webinar. The recording of today's webinar will be posted on the Samba website in the near future for all Samba members to view. We hope you join us for next month's webinar as we hear from Dr. Greta Duncan-Webby on autism in perioperative care. We will send out a notification to members once registration is open. And thank you and have a great evening. Thank you again, Dr. Harvey.
Thank you.
Thanks.